Hello. I'm so grateful that you all came back online. It's a horrible weather day in Michigan. It's been sleeting all day. So it's very great that you're all at home and you're safe and you're not driving around. I appreciate that. Tonight, we're just going to run through two quick cases to just kind of solidify what we learned from the last meeting on interstitial lung disease and rheumatology and pulmonology and the connection between the two. And we want to make sure that we thank our sponsor, Bollinger Ingelheim, for helping us all get together with this presentation. So you can hit the next slide for me, Heather.
Okay.
Thank you.
Thanks. I changed my my picture to a beach because that's where I wish I was right now. Unfortunately, for some reason my camera's not working, but I am here. So, and yes, it is very cold here. So we'll pretend we're at the beach.
Exactly. I love that idea better. Okay, so the first case we're going to do is uncovering the cues. It's just a case-based journey through interstitial lung disease and rheumatic disease. You can hit the next one. So our first number one case is the gentleman says, I thought rheumatoid arthritis was all about the joints. Boy, I felt the same way. My first patient that I had in the intensive care unit that came in on a ventilator with rheumatoid arthritis, I thought rheumatoid arthritis is all about the joints, but we're going to see that it is not. So recognizing and managing rheumatoid arthritis associated interstitial lung disease. So the patient's name is LBJ. He's a 67-year-old male. Presenting complaint is increased fatigue and shortness of breath with mild exertion over the last 6 months. And then you should think to yourself, uh-oh, right there. Past medical history of seropositive rheumatoid arthritis 4 years ago. That is going to be significant in a minute. Rheumatoid factor is very high positive. CCP is positive, so he's double seropositive. Remember, we talked about double seropositive is another warning sign. So he has 2 seropositives. We started on methotrexate, and then adalimumab was added 2 years ago, giving the ongoing disease activity. What features in his history suggest higher risk for interstitial lung disease? Well, he's a male, right? And he has disease activity that is bad, and he's double seropositive, and he's having shortness of breath and fatigue, as well as, exertional dyspnea that's worsening. So on exam, we listen to him with our stethoscope against his skin. We pull up his shirt. I pull up everybody's shirt. I'm bad because I'm old and I don't always ask, but I always think I'm going to listen to your lungs. I pull up their shirt, listen to the lungs in the back, inspiratory crackles on auscultation, and then you have to think to yourself, again, oh no. Normal oxygen saturation. So when the medical assistants roomed him, they got a normal sat, but that was only when he was sitting. He does desat with walking on that 6-minute walk test that we talked about that you could do. Chest x-ray did show interstitial markings. Initial tests ordered. So we ordered in rheumatology, right? We ordered pulmonary function test, which showed FVC or full vital capacity. Is that what it is, Jen?
Yeah, our forced vital
capacity and a DLCO of 41%. So tell me about those numbers. Are those bad, good? Where are we at with those numbers?
Oh, definitely. They are not normal. I mean, you might get a normal forced vital capacity around 65, 75% could be normal in, an older person, but it is low. And the diffusing capacity or the DLCO at 40% is low. And I think of that number as the ability to exchange oxygen in the lungs. And it's definitely very low. We want that to be closer to, 70, 80, 90% would be more acceptable.
Perfect. So then we did a high resolution CT scan because that's what our pulmonary colleagues have told us we need to do, pulmonary function test, high resolution CT scan. And that showed basal predominant reticulations with honeycombing consistent with a UIP pattern. And I don't know if you remember that chart that we showed you last time, that there's different patterns associated with different diseases. And so what should we do next based on the CHEST 2023 guidelines? So we're going to go to the next slide. Obviously, we're going to call our friend Heather or refer our patient to pulmonary as soon as possible because we can tell. And the pulmonary function tests luckily come with an interpretation. So, we know that the interpretation was not good, that we know we need to send this gentleman to pulmonary as soon as possible and make sure that he's getting in as soon as possible because remember, time is tissue. We confirm the diagnosis of rheumatoid arthritis interstitial lung disease with a UIP phenotype. He's been on methotrexate for 4 years, but only adalimumab for 2 years, which that kind of gives me the itchies, because why was he on methotrexate for 2 years if his disease wasn't controlled? That was a long time to wait on methotrexate before we added a biologic, and did that hurt him in the long run? So the reason that we referred him over, of course, because he had, all these symptoms in the abnormal tests. And again, that his risk factors were high rheumatoid factor, older age, male sex, anti-CCP's positivity, and he's considered high risk. And then what baseline of follow-up assessments would we establish for this patient? Well, we're going to, work closely with our pulmonary colleagues. So we're going to do repeat pulmonary function tests. And then the question is, should methotrexate be continued? And every single recent article that I've read about methotrexate says that it does not cause any worsening fibrosis. But I don't know if Heather has a different opinion about it.
Well, we were actually, as a matter of fact, just talking about this the other day in our multidisciplinary meeting. I don't think, the thought is now that it really causes the lung fibrosis, but it doesn't help the lungs either per se. Would you agree with that?
Yeah, totally down with that. Yes. But
Yeah.
it seems like, when the rheumatoid arthritis is better controlled, then the pulmonary disease is better too, do you think?
Yeah, I would agree for the most part.
So we sent him over to pulmonary, and they initiated a new medication for his interstitial lung disease, nintedanib. Am I saying that right, Heather?
Nintedanib, close enough.
Nintedanib. Oh my goodness. I want the brand name. And he was continued on low dose prednisone short term for his breathing as well as rheumatoid. And he was switched to abatacept for rheumatoid arthritis control, which I think is interesting because abatacept is really good for double seropositive rheumatoid arthritis. So I'm not sure that the adalimumab was not helping us. It may have been that it was just added too late, but he was switched to a different agent, which is very, very safe. It's a T cell depleter, which we do not have to worry about infection risk as much with that medication in my personal experience. And methotrexate was stopped. Again, that is controversial, but okay, so methotrexate was stopped in this particular patient. His vaccines were updated, thank goodness, and we're going to do ongoing pulmonary function tests every 3 to 6 months and repeat a high resolution CT scan again with our pulmonary colleagues at 12 months. And what evidence supports antifibrotics for rheumatoid arthritis? Well, obviously, he's already had some tissue damage. And I'm going to let Heather discuss that more. But in terms of biologics, the other thing that we could have certainly put him on would have been Actemra, because we know that Actemra, or the trade name is now, because I have menopause, is gone. So it does have antifibrotic capabilities to it as well. So what do you think about that, Heather?
So I think exactly with the antifibrotics, which would be like an nintedanib, or that classification of medications, we know that it is that rheumatoid arthritis, ILD, like you talked about a couple of weeks ago, is typical to have a UIP pattern, or more common to have the UIP pattern that is on the CAT scan when you look at it, which is your fibrosis. And, oftentimes we see the honeycombing. And we know when we see that, we know that the lung fibrosis will likely progress. So we're really concerned about that. So he's also getting worse in his symptoms as well. And his PFTs are dropping, his pulmonary function test. So I think that's a consideration to add the nintedanib as soon as we can to help slow that lung fibrosis down.
And back to the tocilizumab, which is also known as Actemra, does that help you if we do that from a biologic perspective? Because that's not wrong to switch him to that biologic, which we learned during COVID that does help with pulmonary fibrosis. Or does that really not do enough to really even help you at this point?
No, actually it does. It does. We do like the tocilizumab, or like you call it, the abatacept, to help the lungs as well. So I think that'll help control the inflammation in the lungs as well as probably the joints, like you were talking about. But then the antifibrotic works in a different way, works only on the lung fibrosis.
Perfect. Can you hit the next slide for me? Okay, so summary and teaching points. So high-risk rheumatoid arthritis patients need proactive interstitial lung disease screening. So whenever we have somebody that has the risk factors, right? So they're having more shortness of breath, they're having trouble carrying things up the stairs, they're having more just difficulties with profound fatigue. You're worried because they're high titer seropositive. They may be dual seropositive or triple seropositive, which is possible. And male patients or patients who've had disease for a long time. And then we're going to do a high resolution CAT scan with DLCO, which may play critical roles in early identification. UIP pattern carries a poorer prognosis. So that's one of those ones, that makes you go, oh no. Oh no. Antifibrotics can slow decline and certainly help with life expectancy. So that's really, really important. And then it's really important that we communicate with our pulmonary colleagues to make sure that this is all getting done in a timely fashion and that we're communicating with each other. Do you have anything good? Number 2, you're going to go on there.
No, did you want to add anything, Iris?
No, but I might talk.
Okay. I'll have you add a few things about the systemic sclerosis when we talk about our next case. So this is case number 2, getting harder to breathe. It's progressive ILD and systemic sclerosis, which is scary. So the patient, her name is DA. Her background is she's a 56-year-old Caucasian woman. Her chief complaint was worsening dyspnea over the last 6 months with a dry cough, which often go hand in hand. And then she has this known history already of diffuse cutaneous systemic sclerosis for the last 2 years. So she had the skin thickening proximal to her elbows. She had the Raynaud's phenomenon, and she had reflux or GERD. On her antibodies, she had the positive SCL70. So what's her risk of developing ILD? Iris, what can you say about that?
Well, you remember the 70s are really big numbers. So you have to think about, okay, so this is doing lots of things. This is not just your little crest phenomenon. This is the diffuse systemic sclerosis. So this is more worrisome for interstitial lung disease. So, we are more worried about her. We're worried about people who test SCL70 from the instant we see that antibody. We start worrying about interstitial lung disease, pulmonary function tests, high resolution CTs, baseline.
Yeah. So I think up to 60% can develop ILD, and then up to 25% can get the fibrotic ILD. So it's definitely high numbers, like you said. Definitely someone to keep a very, very close eye on. And for baseline screening, what would we pursue? Of course, we're going to pursue an HRCT or high resolution CAT scan, as well as PFTs as soon as possible. And then referring to pulmonology, we would love to help out with this patient if possible too. So she had the shortness of breath over the last 6 months. She was desaturating on exertion. Her PFTs, her FVC was 71%. The DLCO was 52. So that was coming down from what her baseline was. And then on the CT scan, they seen the early honeycombing with the UIP pattern. The UIP is unusual interstitial pneumonia, and it's just a pattern that we see on the CT scan. And usually if it's a radiologist, especially a chest radiologist, will be able to recognize that pattern. Okay. So what are the next steps in the management? Question, what are the next steps? And would we refer to a transplant team? So we definitely want to make sure she's on a medication, right? It's going to be treating this. So in this case, they're going to start her on mycophenolate, she was started on mycophenolate to help control the underlying disease. And as well, it can help in the lung disease as well. They said refer to a transplant clinic for consideration. Not a bad idea at all. If she doesn't require oxygen yet, they may just say, okay, we're going to get to know who you are, know what your disease is, and we'll follow you over, every 6 months or something like that, just to keep an eye on her. Also, we're definitely going to make sure she has her vaccines. Says about introducing palliative care, maybe could. Palliative care is like it's extra cloak, as they call it, or an extra, person that can help care for the patient, not necessarily end of life care, but it sometimes scares people, right?
Totally agree.
So especially if it's a young person, but it certainly could, depending on how sick the patient is. I would say once if they maybe are not a candidate for transplant for whatever reason, or on a high amount of oxygen, then palliative care might be bit more appropriate. What are your thoughts, Iris?
Yeah, I'm thinking too, again, if it's a newer patient to us, and then, we identify that she's got a reduced pulmonary function test, her high resolution CT is abnormal. I think just absorbing that you have an autoimmune disease is a lot in the beginning. Then you're getting used to the MMF medication, which is not always easily tolerated. And then for us to start talking about referring to lung transplant, that is just she may wander off and not pretend like she doesn't have anything wrong. I know we do see that sometimes it's just so overwhelming that the patients
Mhm.
leave rheumatology, and then you see them back 2 years later and they're like, okay, now I'm ready to accept things have gotten much worse. But they just get so overwhelmed with the diagnosis itself. Sometimes that's just a lot. You got to just say, okay, I think being positive and giving patients hope is really important. That's why we're nurses. So, it's just, so there are medications for this. We can slow the progression, things like that. And just so that we have all our bases covered, we're going to refer you to these other people for help that you probably don't need for a while, but just to keep them on board.
Oh, absolutely. I'd keep that in mind. And then what role of non-pharmacological interventions here? I thought of pulmonary rehab.
Exactly.
That is something that we can definitely help. Can definitely help patients, and it helps, get them moving around with, someone who can keep an eye on them, like a respiratory therapist, a nurse as well there, that kind of thing to help them get kind of back moving around a little bit more. That can help build the muscles up around the lungs and help with shortness of breath. Um, what else for
Well, you told me
non-pharmacological?
last time, that making sure that she doesn't have a feather pillow and that she's not wearing a down coat, and, making sure that their air quality in their house is not horrible. Just like things like that, thinking about, okay, what other stressors on the lungs can we eliminate? Is she living with a smoker? Does she vape? What are those other things that we could do to help her out?
Oh, 100%. Yeah. With the smoking, with the vaping, all of that obviously needs to go. We mean, if possible, right away. And then, just a healthy diet too. I mean, that's really important too. Just those kind of things I would think of for non-pharmacological interventions there. Okay. And how do you monitor and adjust the therapy? I think to see if she tolerates the mycophenolate,
Right.
work up to the maximum dose, et cetera.
Yeah, and the problem with systemic sclerosis is there isn't a really good measurement tool of how are we doing. You know what I'm saying? It's not like there's a sedimentation rate and a CRP that's going to tell us how they're doing with time. You really have to base on their symptomatology, and we don't have a lot of medications. I mean, we've used methotrexate, we've used MMF, we occasionally use rituximab, but we don't have a lot in our armory of medications to slow the disease. That's why we need our pulmonary colleagues to help preserve the lung tissue.
Right. And then I was going to say, we do like, I think on the next slide here, it talks about, well, maybe not, but maybe you talked about already regarding the PFTs every 3 to 4 months, and then the HRCT every year. But the breathing tests really give us an indication if, things have kind of calmed down. If they're stabilized or maybe gone up just a little bit back to where they were, that gives us an indication that the therapy is working. Okay. So summary and teaching points. So recognizing high risk ILD and diffuse systemic fluorosis, we talked about that. We know how important it is to make sure that their breathing's stable when they're diagnosed with that. CAT scans, PFTs, all of that. Early recognition for progressing fibrotic ILD, definitely. Don't want to ignore the fact if they're getting some pulmonary symptoms. We definitely want to make sure that they're not progressing. Immunomodulator therapy and timing of antifibrotics, we talked about that. Making sure they're being treated for their underlying autoimmune disease, which also can help stabilize the lungs. And then if anything is getting worse or progressing in the lungs in line of lung fibrosis, get the antifibrotic therapy, which is the nintedanib, started. Timing for referral to transplant, we talked about that. I think if someone is needing oxygen, they definitely need to see transplant. They may not be a candidate right away, but they should at least be known to the transplant team. And then the use of antifibrotics, again, is going to be when you see any kind of progression in the lungs in the line of pulmonary fibrosis.
And so in those those patients with the antifibrotics, how do you know when to add another antifibrotic? Can you speak to that?
So right now there's two antifibrotics are or have been approved for the last, 10 years or more, which is nintedanib and pirfenidone. They just added that new one that we talked about a couple of weeks ago, which is the nerandomilast. That's an add-on therapy. I
Mhm.
can tell you that we haven't got approval yet from any insurance companies to add that on yet. Um, so we've got it approved for over the last 2 weeks for monotherapy, for somebody who hasn't tolerated the other two. So we're working with the insurance companies, all that kind of thing to hopefully within the next coming months, we will be able to add it on. But honestly, if someone is still progressing on a existing antifibrotic, I would push for them to start on the new one as well. It is FDA approved for that. So it's just a matter of working through the formularies and the insurance companies and all of that.
And I think that I did forget to mention on the last one, the systemic sclerosis, that is the patient that you really have to be very cautious about prednisone with because of the scleroderma renal crisis. And so, that's just something to keep in your mind that these are not patients that we're rescuing with prednisone necessarily because they do have the risk of the renal crisis associated with that disease.
Yeah, very good point. And so the key takeaways from both cases?
Just think it's about making connections. It's about knowing your patients. It's about listening to your patients. And I think that you taught it me too when we did our last case that, it's not about just, are you having shortness of breath and just letting them say, no. It's, are you having shortness of breath when you're walking up the stairs? Can you carry the laundry basket up the stairs? Can you still walk your dog around the block? Or did you stop doing that because you are actually having shortness of breath? It's about inquiring a little bit more about the dyspnea and if it's affecting the patient's quality of life and sort of, getting those little nuggets of information, making sure that we're doing a 6-minute walk test, making sure that we're getting the biox every single time, that we're listening to the lungs every single time in patients who are high risk.
Oh, definitely. Because even a patient I seen today was like, "Oh, I think I feel okay. I feel about the same." But as she had done 6 months ago, she was able to walk like miles. Now she can only walk in her house, that kind of thing. So
Right.
yeah, so just be mindful of that. And how has this shaped your suspicion and management framework for ILD and underlying disease?
I think it's knowing that we have treatments is really, really important because you want to get your patient into pulmonary just as soon as possible because these diagnoses are not a death sentence anymore. And so if we know that we can save patients' lives by getting them in and on these antifibrotics as soon as possible, that's what's really important. I have, I have patients that are on oxygen that are in their 80s now that should not have survived this long in my practice. And it's just incredible, but it's because they're on these newer agents and they're living longer than their life expectancy was supposed to be when you look in the textbook of these diagnoses. So I think it's good that we finally have treatment and then, making that relationship with pulmonary so that you're following up with them.
Yeah, absolutely. Yeah, it's great to see them if they are able to, overcome it. Whereas that years ago was not the case. So, what part of the diagnostic or treatment timeline do you feel most confident in, least confident? Good question. Um,
Don't you think you taught me last time that just making sure that we do the referral from rheumatology to pulmonology, but what does that look like? Like telling the patients if you don't hear back from pulmonology, if you're not seeing them in the next 6 weeks, we need to know because we need to pick up the phone and get you over there.
right. No, exactly. Yeah, yep. Pursuing that, making sure that they actually do have an appointment. Some patients are kind of, waiting for us to like make them their appointment, but we have to like make sure the patient is being an advocate for themselves as well. And I think, I would always refer someone to rheumatology that I have suspicion that it could be from an autoimmune disease, which are many, many of our patients. Mm. So,
That's why I think we're good with the timeline. I think, it's just a matter of being adamant about checking your patient regularly and looking for those high risk patients and then identifying them early.
Yeah, that's a really good point, to see them on a regular basis. Even if you feel like sometimes I'm not doing anything today, I'm not changing anything, that patient is stable. But I mean, I think, if they get lost to follow up and they're gone for a couple of years, they come back, they could, things could have changed significantly. So, and then out in the community, I think really important, that everyone can kind of recognize this, these diseases and make that early, just kind of assessment on the patient.
Just like LBJ said, I thought it was just about the joints. Nope, nope, it can kill you.
Yeah.
It can kill you if we just let it go. So that's important to know and to make sure that we're treating the whole patient.
Yeah. And so I think we could probably open up to questions if there is any.
I did have one quick question.
And
I was wondering, for a patient that has a chest CT that you're suspicious of ILD, their symptoms are suspicious. If they have a normal PFT, does that like lower your suspicion for ILD for something else going on? Have you seen that before?
Well, if you have something on the CT that you're not quite sure about, I would definitely refer them. I have seen that. Lots of times our patients will have a normal breathing test, really, but the CT might have a little bit of something there. Might be ground glass, might be, any kind of like scarring reticulation, anything that doesn't seem quite right. They could still have early ILD, and that still, warrants a consult into pulmonary. Even if they have normal breathing tests, because the lungs have a lot of reserve. And especially in young people, you'll see that their CT might look really bad, but their PFTs are still somewhat quote unquote normal. So I think that's a great question. I think definitely to be aware of that, that they still could have something going on.
Thank you.
good question, Madison.
Just wanted to say hi.
How are you? Thank you so much.
Yes, thank you for putting this together, ladies. It was really nice.
No,
Hi, Heather.
Hi, Anna. How are you?
I'm good. Hope you had safe travels back home too. We were both at PFF Summit, Iris, so it was nice to see Heather in person again. And this is really great.
You like my beach picture?
I do. It's much better than what's outside right now. So
Sorry, I'm pretty sure that Henry Ford, or like where I work, has something set up on the
blocking your
Zoom. Yeah, I think so. I think that was fine, but it's all right.
that's okay. We miss your face, but it's nice to look at a nice view. So.
Yeah, yeah. So, yeah, this is great. I appreciate learning even more about just connecting with Iris and learning more about. There's always things to learn about underlying autoimmune disease. It's so
I think too, to that point, is just going forward and having collaborative practices together, because the more we research this, the more that we look at it, the more we realize how much overlap there is. And having extra sets of eyes on these patients is just important, because something that someone might miss in pulmonology might be caught in rheumatology and vice versa. So it's really great that you guys are working together and, and also doing that outside in your practice as well.
I feel like so relieved to have a connection. My husband used to be a respiratory therapist before he was a nurse practitioner. So that always helps me, because he helps with the pulmonary function test. But also, I have a pulmonology nurse practitioner friend, and I text her CT scan reports and says, am I an idiot? Am I referring this? Am I not? And she's always just very kind. No. You're right. You need to refer this one as soon as possible. So it just gives you so much peace of mind to know that you have a connection out there that you can refer to.
Absolutely. It's like your own personal MDD.
Right.
Yeah. And now I have Iris's number in my phone, so she can't.
Yes.
She can't escape me now. So I appreciate that.
Perfect.
No, this is awesome. Do you guys plan on doing anything in the future to make, keep doing these? Or was this, I know. Yeah.
I spoke to RAP about doing one in West Michigan, because now we've covered East Michigan. So I think we cover the other side of the state. So I'm hoping that we're doing that next.
Oh, cool. Okay. Well, keep me in the loop. I know that they, filter them through to us, but you have my contact too. So just if you, have that plan, just you can give me a heads up and I'll make a point to come by to that as well.
All right. Thank you so very much. I appreciate you. Thanks again for the sponsorship. That was so great.
Of course. And I I know I looked for that one document you said that you really liked. You made a shout out to it here too. And I can't find it anywhere in our anything that I can share, but I'll do some more digging for you because I know it was a nice slide to look at. Yeah. Yeah.
Perfect.
So
Yeah. And if you do go to the other side of the state, I would be more than happy to join you because I have one of my kids over there at college. So
oh, nice. At Grand Valley?
yeah, well,
Awesome.
at Kelvin. Yeah, but
Oh, okay.
Rapids, yeah. So
Well, that
Awesome.
that actually answers the question. So that's good. Thank you.
yes.
Team
All right.
effort.
Thank you, everyone. I appreciate it.